Hello, I'm Melissa Walton-Shirley, and thanks so much for joining us today on theheart.org. And we have two distinguished guests today, Dr. Eric Peterson from Duke and Dr. Eikelboom from McMaster in Ontario. Is that correct?
Correct.
Thanks so much for joining us. We're going to be talking today about antiplatelet therapy. And we had a lot of things that were blood-related this meeting: Trilogy, WOEST, and PROTECT. And I wanted to start with Trilogy. Prasugrel compared with clopidogrel really didn't outperform in patients with medically treated ACS. These were high-risk patients, and at least in the first 12 months, really didn't show much difference. But at the end of 12 months, we noted a divergence in favor of Prasugrel. So is that enough to make you change your recommendation in the office setting for patients?
Yeah, I don't think this changes our recommendations. I think if you had a patient who is put on clopidogrel, it would be a reasonable option in the medically treated population. Now, we have to remember that this is different than we've seen in the earlier trials of early intervention, for which Prasugrel was significantly better.
And I have a question for you about genetic testing. Do you think if we did genetic testing in this setting, we might have seen a significantly different outcome?
Well, that's a tough question to answer. There's been a tremendous amount of literature, debate, controversy about genetic testing for clopidogrel, and I am convinced that the certain genetic polymorphisms involving 2C19 predict outcome. But when we look at the most rigorous evaluation, what effect does the polymorphism have on the efficacy of clopidogrel? Well, there is no interaction that we can demonstrate, for example, in the CURE trial. Now, that doesn't mean to say there's not an interaction in a high-risk stent population, but in this particular population, non-invasively treated, I would it'll be a guess, but I'd guess that genetic testing wouldn't make a difference.
Some of this may be actually answered in the future. Within this study, as we all need to remember, there was embedded a several thousand patient platelet function studies. Those will be able to test out in both acute look as well as longitudinal on-drug look of whether or not the various antiplatelet function studies were both stable over time, dependent on dose, and ultimately associated with outcome in various subgroups. It'll be fascinating.
So are you suggesting that maybe there are biologic mechanisms that just aren't measurable, in our current status today with the science?
Well, that's certainly a possibility. It may be that the genetic polymorphism determines only in part response to clopidogrel. So it may be an imprecise surrogate, and that would be my guess. But I think Eric's point, very important, that this is a very informative trial, and the additional platelet function studies, those data are going to be very instructive, I think.
Okay.
And then I wanted to jump to WOEST. I thought that was really fascinating. Patients on oral anticoagulant for mechanical heart valves received a stent on aspirin therapy, and the study looked at double therapy with aspirin and the oral anticoagulant, and triple therapy versus triple therapy with clopidogrel. And I noted that these were both BMS and DES patients. I was really impressed that the bleeding on triple therapy was 44.9% and on double therapy 19.5%. So my question is, again to you, Dr. Peterson, is this practice changing for you immediately, or are you going to wait for more information?
Yeah, I think that what we have currently in practice is the big problem, right? We have patients who come with atrial fibrillation or other needs for anticoagulation, and then get a stent, and then we're stuck with the choice: do we put them on triples as we had typically thought? The alternative, the dual therapy, we thought was aspirin and clopidogrel. To the credit of these investigators, they were brave enough to say, let's try it without the aspirin. And lo and behold, the results of the study at least show that a remarkable reduction in the bleeding rates without any measurable differences in the outcome. Now, the study was not large, and in an ideal world, we'll have larger populations to look at this to be assured that it is not going to see a higher late event rate either in stent thrombosis or other clinical events. Right now, if faced with that patient in my clinic, I think I'm thinking about the dual in this way, dropping the aspirin.
Sure, it's tempting for sure. And then I have a question for you too, John. Is there any patient that you would say you cannot stop your aspirin? I know about what this trial says, but is there a certain person that you would just not allow that to happen?
Well, I think we're still going to be nervous about drug-eluting stents and early. As Eric has pointed out, the small size of the study means that we can't reliably exclude an excess of stent thrombosis. But having said that, it's likely that the reduction in bleeding, which has serious complications, will outweigh any excess of stent thrombosis. So I think this is a game changer, not necessarily in the clinic tomorrow morning, but it's opened the door to reducing the intensity of antithrombotic therapy in these high-risk populations. And I think another item for the future, this is warfarin plus clopidogrel. The new orals will reduce stent thrombosis effectively, as shown in the ACS trials, and I'd like to see what apixaban or rivaroxaban will do on top of clopidogrel.
Absolutely. I think that'll be the fascinating field, because if anything, the safety profiles have been equivalent or better with these. You've already mentioned the stent thrombosis data, which is very provocative. Now, perhaps in a bleeding acceptable manner, this might be really the game changer, right?
So let's talk about PROTECT next. No difference overall in stent thrombosis with Endeavor versus Cypher at 30 days. But you know, not all stents are created equally, and we were having this discussion earlier about how patients might not really know the difference between the type of stent platform that they had chosen for them. So if a patient comes in and they have a bad tooth and they have a Cypher, do you behave yourself differently as if they had a Xiant stent 7 months ago?
Yeah, I think as stent technologies have gotten better, in general, although PROTECT would back us down a little bit on that, in general, there's been an improvement in the degree of stent thrombosis. It partly represents better technology. It partly represents the idea that I think the placement of these stents has gotten better. The appositions issues have been solved. For the patient who comes in at 6 months, there is this quandary. What do you do? It's a trade-off of can you delay something? If it is a delayable surgery, I still probably favor delaying it. If it's an elective knee operation, I think I would delay upwards to a year to be consistent with current best practice. These data say that if it couldn't be delayed, perhaps we're in a range that the risk is pretty darn low, which is good.
Let's say I call you and I say I have a patient and we just implanted a week and a half ago, and they're septic and infected, and we've got to go in their belly. It's like the worst situation in the world. What do you do pharmacologically? Is there something you can offer me to help protect my patient? How do you do that?
Well, this is the tough patient, the toughest patient, and I think even though there are low event rates in PROTECT, we know that stent thrombosis, the risk is greatest early, and we know that 3 to 6 months, we need 3 to 6 months of dual antiplatelet therapy, at least based on the best evidence. So if you're giving me a patient at a week and a half, I've got a problem. I think there are several strategies. The one that I would favor, which is not based on high quality evidence, is to give a platelet transfusion immediately prior to the surgery. And what that does, if given in sufficient numbers, the platelets will restore the capacity, the transfused platelets will restore the capacity of the blood to make thromboxane. And that's important because we can overcome the antiplatelet effects of aspirin by transfusing a modest number of platelets. It's almost as though we reverse one antiplatelet drug immediately prior to surgery, do the surgery on clopidogrel, and then resume surgery.
So continue both agents up to the time of the surgery, do the transfusion, and then sort of rescue.
That's my personal strategy.
Well, do you have any surgeons that are your friends?
Yeah, I was going to say, how many of your surgeons are going to accept that? Well, John's got clout, so maybe he can move the world.
There are some alternatives, and the use of a short-acting GP2B3A inhibitor is one option that could also be considered. But we're between a rock and a hard place at a week and a half. The evidence supporting the reversal of aspirin is anecdotal, that is in the clinic, but there are people who've used this quite extensively, particularly in Germany. There is also laboratory evidence that we can reverse the effect of aspirin by adding a modest 20 or 30% unaspirinated platelets. So I think it's a reasonable strategy.
What
and
about-
let's remember that a bit of bleeding is never desirable, but if there is a bit of bleeding, so
If the
be it.
trade-off is death, then maybe a bit of bleeding isn't so bad.
Indeed.
Yes.
What about the same patient and it's 3 months everolimus-based stent?
I'm much less concerned.
So you're
because
a cowboy.
I think that at 3 or 6 months, if we look at the event curves, we see these are front-loaded events. If we look at the randomized trials
Yep.
comparing less than 6 with more than 12, we haven't been able to show a benefit of extending. So the risk is not zero, but I'm much more comfortable.
What about stent selection? I mean, what are your thoughts when you have a conversation with a patient that's going for a cath? I mean,
Right, and I think that's the big change that we've had to institute within our groups. The degree to which we really need to talk with patients about the potential risk and benefits of different choices here. In the past, we were so ready to just choose for a patient, you get drug-eluting, you get bare metal. Now I think there's much more of an informed conversation that we need to have. And now it's even better if the drug-eluting doesn't require quite so long of dual antiplatelet therapy. The future will make those differences less, but still discussions I think should be had up front.
sure, and we'll have more discussion next meeting, I'm sure, about the same type of topic.
Exactly.
So thanks so much for joining us today on the heart.org, and thank you very much for joining us as well.